Hi, my name is Elisa Minkin. I'm a general pediatrician. I'm also the chair of the JOMA Preventative Health Committee, and I'm really excited and really honored to be here today with Dr. Mark Mulligan. Hi,
Hello, Dr. Minkin. It's wonderful to be here.
Elisa. Wonderful to be here with you. Dr. Mulligan is the director of the Division of Infectious Diseases and Immunology in the Department of Medicine and director of the NYU Langone Vaccine Center. He joined NYU Langone Health in 2018. By the way, I graduated NYU Medical School.
Yeah.
He is a translational physician scientist who leads a research clinic and a research laboratory. He conducts vaccine clinical trials and clinical studies of emerging infections. He has studied HIV, Zika, Ebola, bird flu, 2009 pandemic, influenza, and other infections with public health impact. He's now studying the novel coronavirus, or COVID-19, or SARS-CoV-2. He's a graduate of the University of Notre Dame, cum laude, 1980, University of Texas Southwestern Medical School, Dallas, 1984. During infectious disease training, UAB, 1987 to 90, he did postdoc molecular virology training with Dr. Richard Compans. What's UAB?
University of Alabama, Birmingham.
Ah, okay.
That's where I was for my ID fellowship, as well as residency.
I see. Thank you. So Dr. Compans is a renowned virologist. Dr. Mulligan served as lead investigator for an NIH-funded HIV/AIDS clinical trial units conducting AIDS and TB research in Atlanta, Kenya, the Philippines, and Thailand from 2006 to 2018. He also served as the principal investigator for an NIH-funded vaccine and treatment evaluation unit 2007 to 2018. This was one of 9 national units funded by NIH to conduct clinical research on medical countermeasures such as vaccines, treatments, diagnostics, biomarkers to combat infectious disease threats to human health. So we're finally rolling out the COVID-19 vaccines, and we really have to put this in perspective of where we are now. So I call this talk No Easy Answers because I'm going to be difficult. I'm going to ask you hard questions because those are things that people are asking, and this is not a time for propaganda. This is a time for transparency, openness and honesty. And I'm so grateful for you doing this with me. So I'm going to start with asking you to tell us where we are now in terms of the virus.
Well, we're in a very difficult place. It's getting worse. Here in the U.S., we're breaking records. We know New York, where we are right now. Last March, April, we had it very difficult, and now the rest of the country is going through what we went through back then, or much of the rest of the country. And think about California, Texas, of course. And internationally, same thing. Places that went down for a while have come back up. We sort of lowered our guard on non-pharmaceutical interventions, things like masks and hand washing and social distancing, quarantine, isolation, testing. We've got to keep doing those things. The vaccines are not going to get us out of the current resurgence that's going on. The way out of this, to get things better a month from now, is all of those things. So we have to rededicate ourselves to that. So I think it's an exciting time because the vaccines have rolled out. I know that we're going to talk about that, but it also is a time to recognize it, to stop the illnesses, hospitalizations, deaths now, immediately. The vaccines won't be rolled out fast enough to do that. Right now, for this first quarter of this year, to get things, to stop the carnage, we've got to go back to that basic old shoe leather public health measures that we know work, and these things do work.
Right. The problem is that we're in a state of pandemnesia.
Yeah.
Right. We move beyond pandemic fatigue to we're just done with it. I mean, and as a human, we can speak to each other and say we understand this, but it's really important. It cannot be said enough. I think people are saying, well, we're just going to go beyond that and talk about the vaccine or talk about, say, the cures that we have, the treatments. I just want you to speak for just a minute on how effective treatments we have for COVID-19 are. Do we have good ones now?
Yeah. I have to say, I think we have modestly good treatments. Remdesivir, there is definitely some benefit, reduction in the length of hospital stay, and a trend towards reduction in death. And then if you add in anti-inflammatories, either steroids or some baricitinib, JAK-STAT inhibitor, there may be some additional benefit, but we're still learning. We don't have a home run treatment, a slam dunk. The monoclonals don't work for people already in the hospital. They are effective for people who are outpatients, who have high risk of progression, hospitalization, death, to keep them from having to go to the hospital. An infusion of one of the monoclonals, 70–80% protective. So I think that's something to use for outpatients relatively early, first 7–10 days. But we don't have we really don't have a great therapeutic regimen right now. We've gotten a lot better. The death rates, I think, in the current increases that we're seeing here in New York, for example, the hospitalization and death rates are much less than they were. So we've learned a lot about the types of treatment that needs to be done: anticoagulation, oxygenation, proning. We're diagnosing people earlier because testing's more available. All of those things have helped, and they're helping people do better. But in terms of a specific therapeutic, we really don't have fantastic treatment, no.
Right, and I think that the point has to be made that we don't have a slam dunk. So when you say moderately effective, we are way better than we were, and we were caught completely off our guard in New York. So I don't want people to misunderstand and underestimate this disease. And it's not even just about survival, right? It's also about long-term effects.
Yes, yeah. I mean, the virus is very dangerous for acute illness and death and hospitalization in people who are at risk. But then there's this whole thing of post-COVID syndrome, which some people have called the long haul, long haulers. And we're learning more and more about this in terms of ongoing multi-organ, potentially multi-organ involvement. And so this is not a trivial virus. It's not the flu, the common cold, anything like that. It's much worse. And we really need to be respectful. I like to say that there's so much we don't know still. As much as we've learned a ton in the last year, but as much as we've learned, there's still probably more than that to be learned. And so it remains a time for us to be humble.
Right.
The virus has humbled us. It has, we have not been perfect in our response in many ways in terms of policy and leadership and, role modeling by those at the top. But a lot of those things are going to get better, I think. But in general, the virus has defeated us. Maybe we've defeated ourselves in some ways, but the virus has defeated us also.
Right. And we just have to be so careful and not underestimate it as we're learning about the vaccine, because we're going to talk about the vaccine, and I'm going to ask you hard questions, and I just want people to understand that the risks of the vaccine have to be weighed against the risks of the disease. And there's a lot of misinformation minimizing the risk of COVID, particularly, even for young people. I know people who were very young and were previously healthy who are now long haulers, and we certainly heard, unfortunately, sadly, there was a death in one of our communities of a 30-year-old who was, quite healthy. Yeah. So, the idea that if you're a certain age, you're at risk, but below that age, you're fine, isn't true.
No. And the other aspect of that is that CDC estimates 40% or more of infections are asymptomatic. Those tend to more often be in younger people, and they can spread the virus. So even, let's say I'm a healthy young adult, I may feel like, well, I'm bulletproof. I don't need to get the vaccine for whatever reason. But just think of it this way. If you get vaccinated, you are then providing protection to the people you interact with. So it might be a grandparent at home, or if you're a nurse or a doctor, it might be your patients, many of whom are vulnerable. So getting a vaccine is in many ways a social act, an altruistic act. I protect myself, but I protect those around me that if I don't get vaccinated and I get infected and maybe have asymptomatic, I might spread the virus to them. And if they're a vulnerable group, older, immunocompromised, cancer, very young, pregnant, those people are at risk for severe complications.
Right, right. So let's start with, in terms of the vaccine itself, what are we learning about it? Because, it had an emergency authorization after a couple months of being studied? In terms of the data?
Yeah, a bit longer. We vaccinated the first the day that the first human got an RNA vaccine, the Pfizer, was May 4th, and we were vaccinating that day here at our institution at NYU. So the EUA was granted for Pfizer on December 12th. So, 8 months or so. So there was phase 1 work and then phase 2. But in the phase 3 data that were presented to the FDA that led to the emergency authorization, there was an average or a median of 2 months of follow-up post-second shot. And I think that's probably what you mean. So at the time that was granted, and it was true for both Pfizer and Moderna, both RNA vaccines that have the EUA, there was an average or median of 2 months of follow-up. And it only took that long. We went quickly in terms of getting to an efficacy endpoint because there was so much COVID. Normally it would have taken probably a lot longer, but because we were surging all over the country and around the world, an answer was obtained very quickly in terms of protective efficacy.
Right. So what do we know now that we have about, 7, 8 months?
Yeah. So now
the original.
We continued to follow. And one of the things we learned is, for example, was published in the New England Journal maybe a month ago, the durability of the antibody is far out now. What was published was 3 months after the second dose. There's still very good, very little drift down. There is some drift down of the antibody titers, the neutralizing antibodies, which we think are an important part of the protective response. So antibody persistence is excellent, outstanding, even 3 months after vaccination. And I think over time, we're going to see these data be extended 6 months, 9 months, 12 months, and we'll learn more. We're just not there yet. So we're still sort of early days. What we can say, I think, is that the RNA vaccines are 95% protective. And those data are going out an average of 2 to 3 months, we'll say now, after vaccination. The vaccines were in the phase 3 trials, the 2 RNA vaccines studied in 75,000 people. Well, now 9 million people have gotten the vaccines in the US. So that's another aspect. Because we're in this emergency, this global public health, US public health emergency, things have been moving fast. And I think that's another area of concern for many people. They say, well, it's too fast, I'm not going to take it. But I'd like to say to everybody that no corners were cut on safety. Everything we normally do, we did in these trials. The way that the speed was achieved was by intense effort, doing some things in parallel that normally happen in series, one after another. And then the companies actually produced doses of vaccine for distribution even before they knew that their vaccine was effective. So that once the EUAs were issued in early mid-December, the following Mondays, we started vaccinating December 14th. So that's how speed was achieved. No corners were cut on safety. And of course, the outstanding safety profile. So outstanding efficacy, 95% protection, and outstanding safety. And that's, with an average of 2 months of follow-up after the second dose. And now that data in the trials will continue in those 75,000 people in the trials. But we also will have the sort of the post-EUA experience now in 9 million people who have gotten these vaccines. And the safety profile, really continues to look outstanding.
Which is great news. Now, what are we learning about the vaccine immunity versus natural immunity? Because, a lot of people say, I had the disease, or I'd rather get the disease because I think natural immunity is better.
Yeah. Yeah, I think my response to that is that I'd much rather get the vaccine than the natural infection for a few reasons. We just talked about the severity, the risk of harm from natural infection. If that's sort of reminiscent of the idea of letting a population become infected naturally to achieve herd immunity. The problem with that is a lot of people will die.
Right.
It's not safe. The vaccine is so much safer than natural infection. So that's one. Number two, this is an immunosuppressive virus. So the immunity after natural infection wanes over time, particularly for these coronaviruses. And we know that it's possible to get a second infection. Some people have had a second infection that's been well documented. And the vaccine duration of immunity, we don't know yet, but my expert opinion is that it's going to be longer and more solid than the immunity after natural infection. So I think 2 or 3 points. The vaccines are safer than infection in terms of inducing immunity. The nature of the immune response to the vaccines is really strong with these RNA vaccines. In many ways, it sort of mimics natural infection without the risk of natural infection. You get a robust immune response with helper T cells, killer T cells, antibodies, B cells, and you get memory. I think the duration of the protective response will be longer after vaccine. We don't know if we're going to have to give a booster. If we do, fine, we'll give a booster. It's okay. We can give that in 1 year or 2 years if it's needed. We'll learn that from the ongoing follow-up of the clinical trial participants.
So I'm going to be difficult here, but for the clinical trial participants, there is an issue, right? And the issue is for the people who are in the placebo arm.
Yeah.
Right? I mean, can they stay in the placebo arm? I mean, if I were in the placebo arm or I didn't know, I'd want to know and get the vaccine. We already know it's good.
Right. And I would say, yes, of course. We will, if you're in the Pfizer trial, we're giving the vaccine. So yesterday in our clinic, our research clinic, we gave 5 of our trial participants who we had unblinded and were in the placebo group, the actual vaccine. So they can get it free in the trial. For the other trial we're doing here at NYU, the AstraZeneca trial, we are unblinding people as their number comes up. If they say, I'm a healthcare worker, I can get the vaccine at work, I need to know I'm in your trial, I might have gotten placebo. So we are unblinding them and then telling them whether they got real vaccine or placebo. If they got real vaccine, our advice is, you've gotten an effective vaccine. Whether it's Pfizer, where we know it's 95%, or AstraZeneca, where based on, we don't yet have the US data and it doesn't receive an emergency authorization in the US, but we know that it's somewhere between 62 and 90% based on the international trials. It's now been given emergency authorization in multiple countries, including UK. So that's but people are able to do what they want. We unblind them, give them our advice, and they can make their best decisions. We just want them to have the right information. But to go back to what the core of your question, once there is a vaccine available through the emergency authorization, and once someone in a trial, one of the ongoing trials, is eligible to get that vaccine, it's no longer ethical to have them continue in the placebo arm. So they're able to cross over. We unblind them and they can cross over if they got placebo. If they got the real vaccine, they're all set. If they got placebo, they can then get the vaccine either through the trial or through their usual standard of care procedure for emergency use authorization vaccines.
Right, because we're balancing, right? We're balancing our desire for knowledge, ideal knowledge, with the real world, ethics.
Yeah.
And I think that that's always been the case. People who have vaccine hesitancy will sometimes say, where are my randomized placebo-controlled double-blind studies of vaccines that we already know are efficacious? And the answer is we can't do them. We cannot put children, for example, give them a placebo when we have a vaccine that can save lives. So that's important, but we're going to still have ongoing data from them from, the past 8 months as opposed to now.
Right, and we will continue to follow them. We'll ask them to stay in the trial and still collect information. And then in addition, an important point, I think, is that Pfizer, Moderna won't be enough. The RNA vaccines, there won't be enough supply for the whole country or for the world. And so we need multiple winning vaccines. That's why we're doing the AstraZeneca trial. That vaccine has advantages in that it can be stored in a regular refrigerator. You don't need the ultra cold or even freezers. And it's cheap. $3 to $4 a dose, as opposed to, say, $19, $20 a dose for the RNA. Plus, they can manufacture a lot, 3 billion doses this year. So that'll be a vaccine that will have be very important globally. But even beyond that, we need more vaccines. There are 7.8 billion people on the planet, and we need more winning vaccines. And so in February, we'll be starting the Sanofi vaccine. There's another trial that has just completed enrollment of 45,000 participants internationally, and that's the Johnson & Johnson or Janssen vaccine. Probably in February, both Johnson & Johnson and AstraZeneca will go to FDA for their EUA proposals or applications, depending on how the data play out over the next month or so. So there are more vaccines coming. We need them. Clinical trials, though, will continue, new trials. There will never be another placebo-controlled trial now that the EUA vaccines are available. What will probably have to happen, and I believe this is what's being planned for the new trials like the Sanofi that will start in February, is that they'll have an active vaccine comparator. You'll be comparing, and it'll become not a randomized, blinded, placebo-controlled trial, but a randomized, blinded, active controlled trial for to show that it's non-inferior, that this candidate vaccine, in that case, the Sanofi vaccine, is just as good or nearly as good or better, or maybe not as good as that, as the EUA approved vaccine. So the ethics will require us to provide an EUA vaccine or a vaccine that we have clinical equipoise, meaning we feel it's very likely that it's going to be protective and it's reasonable to test it in a clinical trial like this.
Right, because it's not ethical to not give someone a vaccine when there is a vaccine. You can't do placebo at that point. And that was always an issue with vaccine education, with vaccine hesitance. Back for just a minute to the AstraZeneca, because I think we've gotten a lot of information about the mRNA vaccines and how they don't edit your, go into your nucleus or edit your genes. I don't know if people are as familiar because it hasn't been approved yet here, but it sounds like we're close. The AstraZeneca is a different kind of vaccine. I don't want to go into it in great detail, but just a little bit because I've heard misinformation about it already. It's not live.
Yeah. So we have multiple platforms or types of vaccines, and the mRNA is one of our platforms, 2 different companies now, both approved for the EUA. And then another platform is the adenovirus, or non-replicating viral vectors. So a weakened common cold virus, it can't even multiply in the human body, it can't make us sick, but one gene, the spike protein gene, the same one that's in the RNA vaccines, is in the DNA of this common cold virus, the adeno, and it gets injected into muscle in the arm. And really it's just like the RNA vaccine, except one step back. So you start with DNA, you make RNA, you make the vaccine spike protein in the body, you make the immune response, and then we know with the RNAs, you're protected, 95%. In the RNA, you go RNA, protein, immune response, 95% protection. Here it's DNA, RNA, protein, immune response, and question mark protection.
Right, but again, it doesn't get into your DNA, because when people hear DNA, they're something like, oh, this is going to affect my genome. This is super scary. Yeah. So it doesn't.
For both platforms, the RNA platform and the adenoviral vector platform, there's no entry of the material into the chromosomes or the DNA. For example, the RNA, it's only in the cytoplasm. It doesn't go into the nucleus. It gets degraded within several hours or a day or two, and then it's gone. RNA is very sensitive, so there's no concern there. Very sensitive to degradation. It's not stable. That's why it has to be stored at really cold temperatures. Otherwise, these enzymes that are called RNases will destroy the RNA. The common cold virus, adenovirus, does not integrate its DNA either into the human chromosome. So that is not a concern.
Right. That's helpful. And the Johnson & Johnson, is that the same platform? It's also a viral vector?
It is. It's a viral vector as well.
Okay.
It's using a slightly different serotype of adeno. It's called Ad26. The AstraZeneca is a chimpanzee adenovirus, but they're both serotypes to which we don't have a lot of pre-existing immunity, which is good, because then we don't attack the vaccine as it comes in, and we get a better vaccine take. Nice thing about the J&J, it's a single dose vaccine, whereas the RNA and the AstraZeneca are 2-dose.
And what kind of response are we seeing to that Johnson & Johnson? I know the AstraZeneca you mentioned before is like 70%.
Yeah, for efficacy, that's right. The average is 70% of the trials in Brazil and UK. Don't know yet for the US trial. For J&J, we don't have any efficacy data in humans yet.
I also heard something about that the change of the dose, using a half dose, I don't remember if it was the half first or the half second for the AstraZeneca, caused actually a higher immunogenicity.
Yeah, that was information that came out, published in the Lancet again about a month ago. And it is a little bit confusing because in addition to, it was the prime, they gave a half dose, and then the boost, the second dose, full dose. In the US trial we're doing, we're giving 2 full doses. Um, they actually did that sort of accidentally. They had miscalculated the level of the dose in that UK trial. But in addition to the change in dose for the prime being a half dose, there were also different intervals. It's supposed to be 28 days, but some people it was longer up to 2 or 3 months. And we know that the spacing between the prime and the boost can affect the magnitude and the quality of the immune response. So it's like multiple things were changed, so it's not entirely clear. It does raise interesting research questions. It needs to be studied, but I think the jury's out on that. And what we're studying here in the U.S. and what would likely get licensed in the U.S. is what we've studied, 2 full doses.
So back to 2-dose vaccines, back to the mRNA vaccines, which is what we're giving out here to a lot of people, thankfully, not as many as we should, but so what are we seeing in terms of efficacy from 1 dose? And what should people expect from that? I mean, what I'm getting at is there are people who are getting the virus even though they've had their first dose.
Right. Yeah, the approved regimen is a 2-dose regimen, and starting a week or 2 after the second dose. It's a 3-week spacing for Pfizer. It's a 4-week spacing between first and second dose for Moderna. And then you wait either a week in the case of the Pfizer data, 2 weeks for the Moderna data, were the endpoints that were studied. Then you have the 95%. But there is data that was presented, there are data that were presented to the FDA in the EUA presentations, and it's publicly available on the website for FDA, that a single dose provides some protection. It's really amazing. It tells you how potent, how strong these vaccines are. Even a single dose of the Pfizer vaccine, for example, the way they did the calculations before the second dose was given at day 21, you have about 52% protection. And then once the second dose is given, wait a week later, and then start counting cases, it's 95%. For Moderna, it's something similar. They actually had between the first and second dose for a 28-day window, but they calculated it a little different. You know, these are separate studies, so you're not comparing oranges to oranges, but they had 82% protection. So
I've heard that.
I think what's fair to say is a single dose will provide partial protection that's probably in the range of 50–60%. But to get the full 95% protection, we need that second dose. We also don't know from the single dose how long it would last. That's not been studied. In general, giving a second dose increases the protection, but it's also going to increase, I believe, the duration of the protection, the immune response. So not surprising that after a single dose, some people are getting infected. That's not how the vaccine's intended to be used. We're not seeing the full effect.
Right. I just want to say that when you give numbers like 50% or 80%, the take home shouldn't be, oh, one's better than the other. People have asked, which one should I get? And I'm like, whichever one you can get first.
That's the one to get. That's exactly, yes, Dr. Minkin, that's exactly what I say. You're not going to have the luxury of picking and choosing.
Right.
And if you put it off, who knows when your chance will come again. We know that it's hard to get appointments, that the supply may be limited at times, that we need to improve the rollout, the implementation. What I tell people is take whichever one you can get. They're both basically the same, 95%.
Right. And meanwhile, you also have to understand that you should not be expecting to be safe from the virus with your first shot. I have to tell you, that's the truth. I got the Moderna and I had this urge to throw my mask in the air, woo, like at a graduation. And I had to take a deep breath and say, I'm not protected yet. Who am I kidding? And I put my N95 back on.
Yeah, no, that's a good point, is that we have to continue the masks while we're going through this until we build herd immunity. And that means, probably somewhere 75 to 85% of us, we don't know the number for sure, having vaccine-induced protection, and maybe, whatever contribution, the natural immunity after natural infection. If we get 85–90% of people protected, then we will achieve herd immunity, which means the pandemic will stop. We'll shut it down. There may be little flare-ups here and there, but most people will be protected. and the virus won't have anywhere to go. It's like putting handcuffs on the virus. It can't find another person to infect, and so you shut down the pandemic. Best guess is late 2021 on when we're going to get to that. So hang on to your mask, Dr. Mink. You still need it. Social distancing. Don't gather in large groups. This is really important. And from the public health point of view, when there's a really bad outbreak, the mayors, the governors have to make decisions about. It's very difficult because of the economic impact.
Right.
Whether to limit restaurants, bars, schools, all of that. This is, unfortunately, those things all work. And while we're building towards herd immunity, it's going to take, many months this year. But while we build towards that, the way to stay safe is to continue with all of the other things, the masks, etc.
It's such a hard message because people so much want to go back to life. Somebody asked a very poignant question. There was an older couple, and they said, when I get my second vaccine, since we're saying 95%, and by the way, 95% is what we know so far in ideal situations, right? I mean, I think we have to expect the real world, numbers to be lower, right?
Maybe a little different, yeah.
Yeah.
Clinical trials are somewhat idealized situations. Right. Then we go to the real world.
Right. So they're saying if it's 95%, how do I know that I'm not in that 5%? What should I do? And I think the answer is you have to, especially the higher risk you are, the more careful. I mean, I know some people will be talking about getting antibodies, and you might want to mention that antibody testing, regular antibody testing won't help you here.
Right. So that's another reason why we have to continue our masks, is that the vaccines are not perfect. They're not, no medical intervention is perfect. So we continue with the masks, as we said. We do not recommend antibody testing routinely after vaccination. And I don't think, particularly because the vaccines are really, really good, 95%. So, and we can have to continue with the masks anyway. So it won't change anything. And you may be getting false information in the sense that, one, a lot of the commercial antibody tests are, they're not necessarily all that great, is one thing. Second thing, they don't all measure the antibodies that are induced by the vaccine. The vaccines have the spike. Many of these tests, the antibody tests, will measure antibodies against other parts of the virus, like the nucleoprotein. They may not measure this vaccine-induced spike protein. So it could be very misleading or confusing. So I do not recommend people go and get antibody tested. Feel comfortable, feel confident. 95%. I mean, that's actually really, really good. Our very, very best vaccines are in that range. Many of our vaccines are 70% protection. The flu shot, unfortunately, we need to have a better flu shot. Many years is 50% or less. Remember, the FDA will license a COVID vaccine if it's 50% or better, because we know that'll help in the pandemic. We're desperate. We need something. Dr. Fauci said he would have been thrilled if these RNA vaccines had been 70%. So 95%, and this is important that people appreciate, this is incredible. These are really, really good vaccines. They're really safe. So I don't think there's any need to go and get tested afterwards.
Right, and even if it's less in the real world.
Yeah, I wanted to just clarify. They shouldn't. There's no need to get tested for antibodies afterwards. If you get sick with COVID symptoms, even after vaccine, of course, go for the COVID PCR testing.
A good one, please.
Yeah.
A good one. Those rapids, some of them are really
yes, exactly.
not good. So if you get sick after the COVID vaccine, because people have asked me this question too, what should you do about the second dose? Are you done? I mean, you had the vaccine and then you had the virus. Would that be like your second dose?
Yeah. Yes and no. So I think it sounds like you're saying you get your first shot and then you catch COVID, and it's laboratory confirmed COVID before you had your second shot. So the recommendation in terms of that from CDC and other experts would be, we don't recommend getting a COVID vaccine while you're sick with COVID. Once you've recovered from COVID and you're feeling back to normal, it's fine to get it. And some people may want to wait a few months. We know that it's rare to get COVID within 3 months, again, to get a second COVID within 3 months of your first COVID. So in this situation, I think it would be fine to wait, delay that second dose, even a month, 2 months, you could wait 3 months. But I do recommend getting it because, again, what I said earlier, the vaccine-induced immune response is very strong. The virus-induced immune response will wane over time. We know that you can get a second infection. We still don't know exactly how long the vaccine response will last, but I know it's really strong and really good. So I'd like people to have that and not rely on the natural immunity. So I do recommend getting a second dose, but maybe wait, 1 or 2 months.
So that actually answers my next question, which is for people who've had the virus, they'll say, I don't need the vaccine, I had the virus. And that is even more so because they didn't even have 1 dose.
Yeah. We had many people in the clinical trials who, although you couldn't be in the trials if you knew you had it, a lot of people were in the trials who didn't know for sure. Maybe they couldn't get tested back in March and April. Maybe they had asymptomatic infection, but we can see that if we look at their antibodies before they got any vaccine. So that's able to be known. And so there were hundreds and hundreds of people. So we know it's safe based on those data. They get good immune responses, probably even stronger immune responses because they've been primed by that earlier infection. So it is acceptable. It is recommended for people with prior COVID to go ahead, sometime in the past, they're resolved, they're not sick, to go ahead and get the vaccine as well, to be sure they have a high level of protection.
Right, and we're not here, by the way, to give medical advice. So if you have any questions, please ask your healthcare professional, because I think it also matters when you had COVID. I mean, some people have it worse than others. I think it's reasonable to say that you can wait 3 months.
Yeah, sure.
Some have said you should wait 3 months. I wish the messaging were a little clearer on this. Should you or can you? Right now, it's kind of up in the air, and I think it's just because we don't know.
Right. When we don't have evidence, we have to be a little circumspect and admit that we don't have strong data and just say, this is expert opinion. And what CDC has said, it's perfectly acceptable to wait up to 3 months, since there seem to be few second infections occurring, few if any second infections occurring in that 3-month window. On the other hand, they also say that once your acute symptoms resolve and you're feeling back to normal, you can go ahead and get the vaccine also if you want to do it sooner. I, in general, suggest that you may want to wait, about a month after your symptoms resolve. And my rationale for that, and again, this is not based on data, it's opinion, expert opinion, but is that we want to let the immune system sort of recover from the acute effector response where everything's all jazzed up, fighting that virus that first week or two. Let it settle back down into more the memory, because now you've got your memory T cells and B cells, and then come in with the vaccine. We know that'll give an anamnestic response, that booster. The first dose then is almost like a booster. And we may actually learn that after natural infection, you only need 1 shot, but we don't know that yet. So right now we're recommending go ahead and get both, once you start the series.
Right. I think it also depends on how high risk you are. So someone who says, hey, I would rather wait and stay in my home and wear my mask, as opposed to someone who says a healthcare professional who's exposed to it every day.
Yeah, all of these questions, we have to balance the risk of harm and the benefit to be gained. So if somebody's really sort of self-quarantining as a matter of routine and not likely to get exposed, that's a different consideration from an ER nurse or an anesthesiologist, or a respiratory therapist in the hospital, or even a frontline worker, an essential worker, someone who rides mass transit daily or is working as a bus driver. Those people are getting exposed all the time, and it's a different calculation. The benefit of the vaccines is very high, and the risk from the vaccines is very low. The risk of harm from infection is high, significant. And there's really not any benefit of getting infected. So,
right. So in terms of expectations, we already talked about how, if you get the first vaccine, you should not expect to be automatically 100% immune. And we should not be surprised to see infections after that. We talked about getting COVID and getting the vaccine. We talked about that. What about issues with pregnancy, lactation, fertility? I know there's been a lot of concerns about that in terms of risk benefit.
Yeah. Again, that's exactly the equation. And the guidelines from CDC, from FDA, and I think these are correct in the absence of data because we haven't studied the vaccines in pregnant women, are this, that for a pregnant woman who wants to receive the vaccine to protect herself and her fetus, and we know that there are more significant outcomes, worse outcomes in pregnant women for both the woman, the pregnant person, and for the fetus with COVID-19. For someone who wants to protect herself against that, it's perfectly fine to get the vaccine. They can make that decision themselves and just go and do it. They don't even have to talk to anybody. Or if they want, they can talk to their OBGYN and see what they say. But the American College of OBGYN has come out with a strong statement, as has CDC, that it is perfectly acceptable. Here's one reason. These are not live viral vaccines. Those vaccines we would never give to a pregnant woman. Like, let's say, a multiplying viral vaccine, like a rubella vaccine, et cetera. So these vaccines have an outstanding safety profile. There's no reason to think it'd be any different in pregnant women. We don't have the data yet. The studies are being done, but again, risk versus benefit. Pregnant woman who is a pediatrician getting repeatedly exposed in her work may elect that, hey, for me, the risk benefit here clearly weighs in getting the vaccine while the studies are ongoing. For a pregnant woman who's totally unexposed, maybe she's going to decide, well, I'll wait. But it's up to the woman. She can be empowered to make the right decision as best she can with the available data for herself and her fetus.
Right. And I'm going to actually explore this in an entire podcast because especially for the Orthodox community, these are huge concerns. And that, also in terms of fertility issues, I could just say here that there's myths going around that we're going to debunk on that separate podcast. I'm not going to go further into that. One thing that we should talk about is what's called the reactogenicity of the vaccine in terms of expectations. That's what I meant to say before, but I forgot. In terms of what to expect, because I think, once you know what to expect, you're not suddenly taken aback.
Yes.
And the second add on to that is if someone's had prior COVID, are you seeing more side effects?
No.
Okay.
No. We in the clinical trials, there was no evidence for that. Remember, we studied 75,000 people in the phase 3 trials for the 2 RNA vaccines. Now 9 million people have gotten it, and it's going to be many more. So we're still learning. We're going to learn new things. But here's what we know. We know that the vaccines are safe and effective, and they're tolerable. So this is what we're talking about, the expected vaccine reactions. This is not a safety issue. It's just how you're going to feel for a day or so after the vaccine. Maybe half of people really won't feel much of anything. The first dose is better tolerated than the second dose. So there'll be a few more of the reactions with the second. Older people have fewer reactions than younger people. Their immune system is getting older. It doesn't react as strongly to a vaccine. What are these reactions I'm talking about? We put them in 2 buckets, the local reactions in the arm and then the systemic reactions where you feel all over. So the local reactions, the main one is just pain or discomfort at the injection site. It's about like a flu vaccine, there can be arm soreness. First dose, maybe 30–40% of people will report pain in the clinical trials. Second dose, maybe 60% or so. Nothing, and it starts within a day and it goes away within a day or so usually. No problems. And what I always tell my patients is it's a good thing. It means your body's reacting, and this is a small price to pay for 95% protection. All right, so that's the local reactions. What I call the systemic expected reactions include most commonly things like headache, chills, a feeling of tiredness, or a little bit of just feeling not great. And again, starts within a day, lasts for a day or so, and then you're done. Usually by day 3 or 4, all of these are gone. Usually these are mild or moderate at most. It's very rare. Fewer than 5% have severe reactions that would, keep them from doing their normal activities. A mild reaction is it's there, but it doesn't keep you from doing anything you would normally do. A moderate reaction is one that, I feel it more than that, and it keep me from doing a few things. And then a severe reaction would be one where you're kind of just staying home and you really feel bad. Those are rare. Those are, like I said, under 5%. So to summarize, mild to moderate reactions, they're expected. They're not a safety issue. We in fact, I'm happy to see these in a way, because it means your body is reacting to the vaccine the way it should. And all of these go away within a day or so. And then at the end of the vaccination series, it's a small price to pay for that 95% protection.
Right. And without giving medical advice, so just to quickly say, you can take Tylenol or Motrin. Some people are afraid that they won't mount a good immune response or it's dangerous or something like that. You do not have to suffer.
Right. When I got my first vaccine, all I had was a sore arm.
Me
Last
too.
week I had my second one, and I had a little bit more of a reaction. I had it in the morning. That night, I felt a little achy. I had a little bit of a chill sensation, and I had a headache. I took some Tylenol, and then I was able to go back to sleep, and I felt better. The next day, I still had a little bit of headache. I took some more Tylenol. I think I took Motrin that time, and then I was better the rest of the day. So absolutely, we studied the vaccines, allowing our clinical trial participants to take these these Tylenol and Motrin. It's perfectly fine to take them if you feel like you want to, if you're having one of these expected mild or moderate reactions.
Now, can you mix and match the Pfizer and Moderna?
We don't recommend that. It hasn't been studied.
If it happens by accident, though.
Well,
or because you couldn't get it. And
yeah, I mean, I think things like that happen, once it's again, the difference between a clinical trial and the real world.
Right.
People are going to move in between, be in a different location. I say go ahead, get it. And probably you're going to have a level of protection that's similar. We just don't know. We don't
have data.
So we don't recommend it. But if you're in a situation where the alternative is not available or limited, I'd say go ahead, especially knowing that the vaccines are very safe as they've been studied.
Right. Is there different reactogenicity? Are you seeing different profiles of side effects between the Pfizer and Moderna?
No, they're really about the same. There's not much difference at all.
Do we have any data on, I know that they said we do not know whether you can still transmit the virus even though you won't necessarily get sick. Do we have any data on that yet?
Yeah, what we know, the 95% refers to laboratory confirmed COVID-19 disease. So people that get sick, it's reduced 95% chance of that, 95% reduction with the vaccine. We will eventually know if you can prevent asymptomatic infection. So what we're saying is we can reduce symptomatic infection by 95%. We don't have the data yet for whether people who, remember, CDC says 40% of infections are asymptomatic, whether the vaccine will prevent that. I expect that it will. In general, with viral vaccines, what we say is they may not totally prevent infection, but they prevent disease. A little bit of infection may occur, and then you snuff it out before there's any illness with the immune response from the vaccine. I think that's likely what's going to happen here. There may be a very short bit of infection, but I think before somebody would transmit, the vaccine is going to shut down asymptomatic infection as well as symptomatic infection. But we have to stay tuned for that. We don't yet know. And if we shut down asymptomatic infection, that would shut down transmission. We don't have those data yet.
Right.
In the 95% protection, I think what we're saying there is we're knocking down the virus, nobody's getting sick, and almost certainly that's knocking it down to a level where they're not going to transmit. But those data are not yet available.
Right. We don't know, so still wear your mask.
Wear the mask.
Yes,
still.
exactly. That's what I was thinking. I know I'm almost done with my time. I'm going to just try to get in, if I can, one or two more questions really quickly. Monoclonal antibodies are being used more now. Can someone who gets the virus after the vaccine still get the monoclonal antibodies?
Yes. CDC's guidance here is that having prior vaccination for someone who then gets an infection should not change the therapy, whether it's remdesivir, monoclonal antibody, do it.
Right. Now, once you get the monoclonal antibody, is there a wait period before you can get the vaccine?
Yeah, the recommendation here is to wait 3 months. For the theoretical risk that the monoclonal might interfere with vaccine take. So if you've been sick, you've gotten the monoclonal, remember, we're saying if you've been sick, you can wait up to 3 months anyway, so it's not that much difference. You've been sick and gotten the monoclonal, the recommendation is wait 3 months because of the half-life. The monoclonal has a half-life of about 21 days, so it takes a few half-lives for it to fall to a low or undetectable level. And so 3 months gets you there, and then you'd likely get a really good vaccine take again.
Right. And one more question. I really appreciate your time so much. The UK and the South African variants and the vaccine, what do we know?
Yeah, so this is a hot topic right now. I think it's likely the vaccines will protect against these variants as well. And here's why. The variants are reputedly causing more transmission, and there are modeling data and epidemiologic data that suggests that in UK, South Africa. And there may be, with these variants, which means there's been a mutation in the viral sequence, biological reasons that would explain that. Maybe they attach to the viral receptor more tightly. Maybe they have higher viral titers and so are more easy to spread. But we don't know all that yet. Mainly it's epidemiologic data and modeling that indicate this must be a more transmissible. And we're starting to learn the biology that might support that on the virus. So stay tuned. Then the other big question is, will the vaccines protect against these variants? And I feel almost certainly the answer is going to be yes. There's some preliminary data from Pfizer that one of the mutations that is in the UK variant is neutralized well by vaccine sera. When Pfizer published one of its early papers in Nature, they looked at 17 different viral variants. This was before the UK variant. They were all equally neutralized. RNA viruses tend to mutate. This is sort of their job description. It's not unexpected. This happens all the time. And most of these variants are not going to change enough to affect the protection from the immune response. The spike protein induced vaccine immune response targets multiple places on the spike. So if you mutate one, you've still got the other, let's say 8 or 10 epitopes that are still getting protection, leading to protection. So that's the good thing about having this large spike protein in the vaccine. There are multiple places and ways that the vaccine is providing protection. So it's unlikely that a single mutation is ever going to affect that because you've got all the others there. It's as if you're giving a combination of monoclonal antibodies, if you will, multiple ones. We still have to learn more. So my feeling is that we're going to hear and learn very soon that the vaccines will continue to provide protection against these variants.
Well, I really hope so, and I'm going to leave you alone. I'm not going to make you talk about vaccine access, which is a whole other podcast, but I hope this information is helpful for people who, may still be on the fence and want good information, and I cannot thank you enough for doing this with me.
Well, you're very welcome, Dr. Mencken. It was a real pleasure. I enjoyed it.
Thank you.
Bye-bye.